Warmly welcome to the Aeonmed webinar series. This is Mary, Clinical Application Manager from International Marketing Department of Aeonmed Group. And I'm so happy and honored to have all of you to meet here and chat here, discuss it here today. And we invited Dr. Zhang Yujie to share her clinical experiences and opinions about perioperative lung protection. She's now the attending anesthesiologist in our Beijing Friendship Hospital of Capital Medical University, and which is one of the highest levels of hospitals in China. And also, she has been in teaching in International School of Capital Medical University for more than 10 years. And many thanks to Dr. Zhang. And our guest professor today is Dr. Fangxiao. He is now chief physician in Beijing Friendship Hospital, and more than 25 years clinical working and teaching experiences in the anesthesiology make him have a very deep understanding in his daily work towards every patient. And his National Committee of the Perioperative Organ Protection branch of the Chinese Society of Cardiac, Thoracic Anesthesiology, and also member of anesthesiology branch of Beijing Medical Association. And many thanks to Dr. Zhang and Dr. Hong and all of you to join our webinar about perioperative lung protection today. And if you have any questions or concerns during the webinar, please feel free to type in the chat box in the middle bottom of the software of our Zoom. And we will have a Q&A part after the speech from Dr. Zhang and introduction of Aeonmed 8808 and Vision Workstation. And next, I will give the time to our Dr. Zhang next.
Okay, thank you. Can you hear me clearly?
Yep.
Okay. Okay. Can you all see the slides here?
Yeah, it's there.
Okay. Okay. Now start. Good afternoon, everyone. It's my pleasure that I have this great opportunity to communicate with anesthesiologists from other countries. As Ms. Nie introduced me, I'm from Department of Anesthesia from Beijing Friendship Hospital, and I've been working here since 2010 and as an attending doctor. And my major work is, of course, the clinical anesthesia, and since our hospital is also a teaching hospital affiliated to Capital Medical University, so I do have teaching tasks that include clinical teaching for residents and, of course, academic courses for international students from CMU. Okay, today our topic is a very popular theme in recent years, which is perioperative lung protection. And since the first general anesthesia was performed publicly at Massachusetts General Hospital in 1986, lung, or to say pulmonary function, plays a very important role in anesthesiology. And along with the first invention of the anesthesia machine with a ventilator, which is in 1910, controlled machinery ventilation became possible for us. And nowadays, our task, which is already beyond clinical anesthesia, turns into perioperative medicine. So we pay more attention about patients' outcome and organ protection even after the surgery. Okay, and currently we have over 300 million surgical operations done worldwide in a year. And the indications of surgical operation is expanding because of the development of the surgical techniques. And thus we face a lot of different patients with more complicated situations. And the postoperative pulmonary complication, PPCs, the rate is about 5% to 33%. And it's even higher in specific surgeries like neurosurgery or cardiac surgery or thoracic surgery. It is very high rate. And when people have suffered from the PPC, the 30-day mortality rate could reach 22%, which is very high. And of course, it's not only the poor prognosis, it's also have hospitals, the patient's hospital stay and the costs are extended too. So, and according to the European Perioperative Clinical Outcome, the PPC was defined as pneumonia, respiratory failure, atelectasis, and pulmonary embolism and pleural effusion. And there are many risk factors too, and they are mainly arranging from 3 parts: patient, surgery, and anesthesia. And what we can do is to distinguish them and minimize them, especially for those caused by anesthesia. So today's content will be, first, we will review the mechanism of lung injury, and then for a better understanding of the strategies. And then I'll show you how to apply these strategies in a real case. Okay. So the first part, the mechanism of lung injury. Okay. I always describe the lung as the most fragile organ, and because that is mainly because any pathological changes happens, the pulmonary function will be easily affected. That is mainly because the function unit of the lung is only a very thin membrane called respiratory membrane. It was composed of the pulmonary surfactant, alveolar epithelium, epithelial basement membrane, and interstitial layer, and of course capillary basement and basement membrane, and the capillary endocellular layer. And in the 2 ends of the respiratory membrane, there are alveolar cavity and blood in capillary vessels. And any change of these 6 parts will affect the pulmonary ventilation efficiency. So what are the factors? First, the surface, the pulmonary ventilation efficiency is proportional to the surface area of the respiratory membrane, and is inversely proportional to the thickness of the membrane. And of course, the partial, for example, when pulmonary edema happens, the interstitial layer is thickened, and so that it will finally affect our respiratory ventilation efficiency. And then, of course, the partial pressure and the solubility of the gas passing the membrane also affect our ventilatory efficiency. That's mainly oxygen and carbon dioxide. And then the final part is the ventilation perfusion ratio. When we say the VQ ratio is when it reaches 84%, it's the best fit for a dot. But when ventilation perfusion mismatches, the oxygenation condition will change. Okay, is the ventilation reduced, just like the picture on the left, the blood went through this poorly ventilated area, cannot be oxygenated, cause a intrapulmonary shunt finally. And if perfusion was disturbed, just like the picture on the right, it causes a physiological dead space and eventually reduce oxygenation. So, and when we perform general anesthesia, intraoperative, of course, we need to give the patient a positive pressure ventilation. That is inevitable in general anesthesia. And if it is inappropriate, it might cause these changes, and we call it the ventilator-induced lung injury, VILI. Okay, the mechanism include 5 parts, which is barotrauma caused by high pressure, water trauma caused by a high volume of ventilation, and atelectasis caused by the alveolar atelectasis, and of course, oxytrauma caused by the high concentrated oxygen, and a biotrauma caused by the inflammatory factors. And this picture shows how these traumas make our lung, we'll say sick. Okay, first, when the lung is overventilated or poorly ventilated, the barotrauma, when it's over-ventilated, barotrauma and the water trauma can cause the alveolar wall broken, just like the picture here. And if atelectasis happens, it can cause reduced surface area and thickened membrane, just like this picture. And although the ventilation is associated with the partial pressure of oxygen, just as I mentioned, the overload of oxygen can also cause damages. That is mainly because these reasons. The oxygen first will be absorbed. And if we give the patient pure oxygen at 100% of oxygen, and last, it will be absorbed by the alveolar. And with the lacking of nitrogen, the atelectasis finally occurs. And if we give the patient too much oxygen, the radicals can disturb cell hemostasis as well. And then they can, of course, cause the vasoconstriction of the capillary and finally reduce the perfusion of the lung. So these three reasons will cause the oxytrauma. And then all these traumas can cause the biotrauma. They will lead to the release of the inflammatory factors, and then they will finally go into the circulatory system, then to the other organs of the human body. So if we want to protect the lung, what we do is to protect or reduce the harm from the mechanical ventilation. Okay, here's the next part. Is about what can we do. That's the protective strategies. Okay, on 2019, a expert consensus recommendation was established on BJA. It is based on previous studies, raised up several recommendations, and with rounds of selection, the most agreed ones were established. It can conclude strategies for these 5 parts, mainly the induction of anesthesia, the optimal intraoperative ventricular setting, alveolar recruitment maneuvers, ARM, and the intraoperative monitoring for lung mechanics and oxygenation. And the last part is the emergence of anesthesia. Since I also included some recommendations from other studies, I tagged all the recommendation from this paper with the star mark, and the strengths would divide into three parts, with strong recommendation, weak recommendation, and the statement. Okay. And I reorganize these recommendations by process of the surgery. So it's easier for us to understand and remember. We need to assess the risk and take precautions before the operations, and apply protective management during operations, which is intraoperative management, and then give treatment and patient education after that. Of course, the second part will be our main concern for this course. Okay. As we mentioned, the main task before operation is to evaluate the risk, and clinical risk factors are essential among them. And the recommendations suggested to use a delegate score, but since no score system had a strong clinical evidence to support, so non-specific index was nominated in that paper. I listed these 3 indexes from other studies, and among them, the assess respiratory risk in surgical patients in Catalonia. That's a risk index, has shown a higher effectiveness of predicting the PPCs, and then the others, and the multiple studies. So I also put the picture here. We can see that this is relatively simple and easy to assess. And although in that recommendation didn't list a certain index, but it gave all the risk factors in the statement. And these are all the risk factors. It includes age, BMI, ASA, and OSA, etc. So when we're when we're assessing the risk, we should consider all these factors here. Okay. And the biomarkers can also be used to evaluate, but the studies are mostly concentrate on the predicting of ARDS and the ALI. And I listed all these 7 markers here, which showed effectiveness in the studies, but their relationship with the PPCs is still need further research. And of course, the pre-existing pulmonary disease can also cause a exacerbation of the PPCs. We need to control or give extra examinations before the surgery. They include first, poorly controlled asthma, which may lead to a severe hypoxia during or after operation. And that should be treated before any elective surgery. And patient with these patient with either one of these following conditions could be diagnosed, defined as a poorly controlled asthma. And of course, COPD, which is chronic obstructive pulmonary disease, is an independent risk factor for PPCs. And the severity of the COPD should be assessed using the FEV1 FVC percentage before the surgery. And if the patient have symptoms of coughing or expectoration or dyspnea, the elective operation should be delayed and for treatment. Okay, for patient with interstitial lung disease, ILD, an extra cardiac examination like ECG or UCG should be used to evaluate the right ventricular function. And supportive treatment and consultation from a respiratory physician is also needed. And if a significant atlaxis caused by any reason might be a very important risk factor for PPCs. If possible, for example, if the patient have a pleural effusion, a treatment should be done like drainage before the surgery. And the next is smoking. Although smoking is not a diagnosed disease, but it's a very common situation for patients, which can also increase the risk of PPC and delay the discovery. Japanese societies of clinical anesthesia recommend a 6 to 8 week smoking cessation before elective surgery. And but it's very hard for the patient to follow that medication. So. And the next part will be the intraoperative non-protective strategies. Okay, for induction phase, we may use massive prednisolone and phenylalanine for as they before anesthetics, as they have the anti-inflammatory or and anti-stress action. And from the recommendation of BJA, they suggested a beach chair position for the patient, which is head up over 30 degrees. In this position, we can avoid the ZEP, that's the zero endotidal tidal pressure for the patient. And if the clinical situation allows, we need to try to avoid the flat spine position. And for intubation, they also suggested using a non-invasive positive pressure ventilation or a continuous positive pressure, continuous positive airway pressure or before the loss of spontaneous respiration. And then we need to observe the breathing pattern to identify upper airway obstruction. And once obstruction was detected, a nasal or oropharyngeal airway should be placed to reduce the upper airway obstruction. And after intubation, the fraction of inspiration oxygen, FiO2, should be set to lower than 40%, which we can use the minimum amount to as long as the saturation is above 94. And as you could say, this is a weak recommendation. And when we apply it, I suggest you for your own experience as well as the patient's conditions. Okay. And since there's, sorry, I missed the ventilation mode. And since there's no strong evidence to support any kind of the mode, which is volume controlled ventilation or pressure controlled ventilation, no specific mode is recommended. That means you can use both of the mode as long as it fits the patient. Okay. And the most important part of the day will be the intraoperative lung protective ventilation, which is LPV. Okay, there are three basic concepts of LPV, which are low tidal volume, positive and expiry pressure PEEP, and alveolar recruitment maneuver ARM. And these three strategies, were not new for us. Well, they have been proposed and studied for over 20 years. And first for the patient in ICU, and now is improved for the surgery patient. Okay, then let's look into the details and what is a new discovery about them. Okay, I think as experienced anesthetists, we're all familiar with what a low tidal volume means. It means like it will be defined as 6 to 8 millimeter per kilo. But a lot of people use the patient's actual weight to calculate it. It is okay for a patient with a standard, it is okay to, it is okay for a patient with a standard weight, but if the patient is obese or extremely weak, it might not fit. So using the predicted body weight, PBW, is more accurate. And the formula, this formula is a simplified formula for PBW. It divides patients into male and female, and I strongly suggest we use this formula when we're calculating the tidal volume. And PEEP can also avoid lung atelectasis during controlled ventilation. The BJA recommendation strongly suggests to set the PEEP initially at 5 centimeter water column and to avoid the deep zero and expiratory pressure and throughout the whole surgery. Is 5 centimeters PEEP appropriate for every patient? I think it's not. The BJA recommendation suggests it to use the individualized PEEP to achieve a lower driving pressure. As we say the driving pressure, it refers to the difference between platform pressure and PEEP here. And we used to say that high airway pressure can cause lung injury, but the pressure really usually meant the maximum inspiratory pressure, PIP. But actually, the study shows that PIP was not a predictive factor for PPCs, while the driving pressure is. So we should change our mind that we really should avoid is increase of driving pressure, not the maximum pressure. And it's relatively easy to calculate. And of course, advanced anesthesia machine can provide the data directly. And for a specific patient, the PEEP must be adjusted, like obese patient or patient receiving the laparoscopic surgery, that is pneumoperitoneum operation, or the patient with Trendelenburg position, which is had low leg lifted position. Okay, the next strategy is, of course, the ARM, so alveolar recruitment maneuver. First, I'd like to ask questions. Do we need to perform ARM on every patient? Actually, the routine ARM does not have a high quality evidence to be supported, but the recommendation still suggests using it when considering the risk-benefit assessment. That means if patients have high risk factors before the surgery, although he or she might not suffer from a lung injury, we can still consider using the ARM for more benefits. And then using a back squeeze to form might be the most convenient way. That means manual ARM, but ventilator-driven ARM is more safe and effective. Both And one thing we need to notice that both two ways of ARM might cause a hypotension or even arrhythmia during doing it. So continuous hemodynamic monitoring is essential. And in order to avoid all these complications, we should use the lowest pressure, the shortest time, and fewest numbers of breaths, which are effective. And since ARM without PEEP has limited benefit, it was revealed in multiple studies. PEEP is also necessary and should be individualized after every ARM. That means every time we performed a recruitment maneuver, we need to adjust PEEP again. Sorry, something happens. Okay, here. So, I'm sorry. Give me a moment. The slide has something wrong. Okay, where were we? Sorry. The application collapsed. Where were we? Okay, here. Okay, can you see the slide right now?
Yep.
Okay, just as I've mentioned that the ventilator-driven ARM is more favorable. Then how can we perform it? Okay, there are three ways. The first one is vital capacity ARM. The second one is pressure controlled. The third one is volume controlled. For the vital capacity ARM, its mechanism is the same as the manual ARM. We first set APL value to 30 and 40 centimeter water column and choose the CPAP mode. Then set the inspirator time for 7 to 8 seconds and maintain it for 20 to 40 seconds. And for pressure controlled ARM, we choose PCV mode and set the controlled pressure to 15 to 20 centimeter water column. And the PEEP was set in 24 to 30, and the maximum inspiratory pressure was set to 40 to 45. And continue the pressure control ARM for 2 minutes. But in recent years, the ascending PEEP was more recommended. That means instead of directly set the PEEP to 25 centimeter, start with 5, which is a normal PEEP, and then add 5 centimeters water column every 3 to 5 breaths until the maximum pressure reaches 40 to 45. And the last one is the volume controlled ARM. We start with the tidal volume of 6 to 8 millimeter PBW.
Excuse me.
Yes.
And, it seems that there is something, connection problem with us, because some of our doctors said they cannot see the slides clearly. So shall we wait for like 5 or 10 seconds later to continue, please?
Okay. Okay.
Yeah. I'm sorry. So, dear doctors, it's good now. Is that okay? Because probably there is something happened on the connection, the network, something happened there. So probably somebody is getting clear slides or clear display, but No slide.
so wait.
Not yet. Okay, we will wait for like a couple of seconds to see whether we can back to the clear one.
Okay, sure. It's not my problem yet.
I don't think so. Probably there's
Okay.
something wrong with the connection.
Okay.
So Dr. Zhang, would you mind to change to switch to the last one and back to this one? Let's test
Last one,
whether it,
last slide.
yeah,
Okay.
last slide. Let's see whether it's okay for now.
Oh.
Because I can see it clearly here, so I'm sure. Yeah,
I'll show
I'm
you
sure.
again.
I'm sure part of our doctor's problem is not so clear, so we're trying to figure out whether it's okay for now.
Okay. So you can see this clearly, right?
Yep.
Okay. It doesn't matter, I'll wait.
Okie dokie. So let's continue, please. Probably,
Oh, it's
yeah.
okay right now?
I
So-
guess so.
Okay, then should I go on?
Yes, please.
Okay. We were talking about the volume controlled ARM. We can start with common tidal volume 6 to 8 millimeter of PBW and set the inspiratory expiratory ratio to 1:1, and then increase our tidal volume 4 millimeters per kilo for every 3 to 6 breaths until the platform pressure reached 30 to 40 centimeter water column. And for newer anesthesia machines, the RM mode model is included, which is just like the picture on the right. You can see there's a recruitment maneuver setting for the on here, and we can see we can set the PEEP changes to 5 centimeter water column, and it'll make more easier to carry out the ventilator driven ARM. Okay. This picture shows the major studies about the LPV in recent years, and all these researchers about the tidal volume and the PEEP on the first column agreed on that it's better than no PEEP, and it's better than no PEEP. It means low tidal volume with a high PEEP is better than low PEEP. And the low PEEP is less, which means less than 5 centimeter water column is better than the high PEEP, which is above 10. But we need to pay attention on that. On the third column, the studies of the oxygen fraction had a different result. That's why all the recommendations about the oxygen fraction is weak in that BJA recommendation. And we should focus on the IPERP studies carried in Spain on 2018. Actually, the major outcome for this experiment is the individualized PEEP is better than the fixed PEEP. So actually, here is some mistake here, which is individualized PEEP are better than the fixed one. So that is why individualized PEEP are recommended in the BJA recommendation. Okay, then how to determine the best PEEP number for every patient when the conditions are variable for each patient? There are many methods, and among them, the thoracic CT scan is the golden standard for determining the PEEP, but it's difficult to apply during the surgery. And measuring the esophagus pressure is invasive. And if you use the oxygenate index, that will need acupuncture, and of course, cost more time for every adjustment. So, is there a more convenient way and more instant way to determine the best PEEP? Okay, and compared to all these methods, the pulmonary dynamic compliance is more convenient and popular in recent studies. Just like I said, in the 2018 IPROVE studies, they used the dynamic compliance too. And the dynamic compliance was described as the tidal volume divided by the pressure difference between maximum pressure and PEEP. When it reaches the highest, it means the ventilation and pressure matches the best. The lung is sufficiently ventilated that keep alveolar opening and not overload. This is also called the open lung approach. To find the best PEEP using the dynamic compliance, we need to set the PEEP to 20 centimeter water column first, and then decrease 2 centimeter every 10 breaths, and record the dynamic compliance. When the compliance start to drop at a certain point, the PEEP before that is the best match. That's a match. And there's also, so it is more easy to get, and of course, it can decrease the risk of PPCs compared with a fixed PEEP. But also it has disadvantages because it requires the ventilators to have a dynamic compliance monitor. And of course, if the the lung injury is minor, the change may not be that significant. And it might be difficult to determine what is the best PEEP for the patient. Okay. And besides these three core strategies, there are some more other suggestions. For anesthetic choice, the inhalation drugs are better, and for muscle relaxant, a short-term one is preferred than the long-term one, the long-term NMBDs. And of course, we should use the antagonist before we extubate the patient. And the dexmedetomidine using during operation can also have a anti-stress and anti-inflammatory action. So these drugs are suggested. And for fluid management, a goal-directed restrictive strategy is recommended. It should be monitored by the SVV, stroke volume variation, or pulse pressure variation to monitor the circulatory capacity. And for those weak or elder patients, it might cause a hypotension. So the combination using of the alpha-1 receptor stimulant should be done. Okay. Oh, sorry. It might be not seem clear, but it's also very important to optimize the left ventricular function during the general anesthesia. Since when we have a left ventricular failure or dilatory dysfunction, the pressure in the left ventricle will raise as long as the left atrial, and then it will eventually cause a raise in the lungs capillary pressure. So it might cause the hydrostatic pulmonary edema. But monitoring that is quite difficult. The cardiac cycle effects monitor is not very common, and the TEE is also invasive. So for daily use with a common patient, we can just simply maintain the basic heart rate for the patient. Okay. And at last, during the emergence of anesthesia, we should also pay attention to avoid the ZEEP. And one thing we've done a lot in past time was suction through the tracheal tube before or during the extubation. But that is a wrong move. The BJA recommendation suggests to avoid that immediately before extubation, since it could lead to ZEEP. And low fraction of oxygen during emergency was recommended too. And if patients, the saturation of oxygen can stay above 94% with room air, extra oxygen is not necessary. But if the patient have underlying causes, that means may have high risk of hypoxia, the oxygen fraction should be higher than that. And of course, if the patient used the CPAP before surgery, I think for precaution, we should use that too after the surgery. Okay, for post-operation, our main task is to provide appropriate analgesia. The combination of opioids and NSAIDs and the multimode analgesia can give a better effect and reduce the dosage of opioids, which is especially important for the OSA patients. And supportive therapy and patient medication can also reduce the rate of PPCs. We should encourage the patient to exercise early, and if he can't, the CPAP should be used as a support. Okay, that's all the strategies for today. And we could notice that these three trends of lung protection. The first one is risk evaluation should be accurate and quantified. And then the LPV, the lung protective ventilation, should be individual and goal-directed. And we should care more about the long-term outcome for the patient. That is not only for the lung protection, it's also for all the anesthesia management for today's patients. Okay, and that's all for the second part. Then I'll use a case to show how we apply these protective strategies. Okay, I'll introduce the case briefly first. Okay, this is a case of extremely obese patients diagnosed as a metabolic syndrome. Okay, he will be receiving the laparoscopic vertical banded gastroplasty, and his weight is 229 kilo, which is 3 times of his PBW, and the BMI was 78.4, which is very high. And his major problem is that he has severe OSA, obstruction sleeve, and apnea too. And the AHI was nearly 43 times per hour, and the longest apnea time is nearly 1 minute. So the major problem will be the severe OSA, and of course, it will cause the difficult airway. Okay. This is a picture of the patient. The doctor stand by him is my colleague, Dr. Wan, who performed anesthesia for the patient along with Dr. Hong. He is already a very strong man, but we can see the patient's size is nearly 2 times of Dr. Wan. And when he lie down, we can hardly see his neck. So that will definitely cause a severe OSA and cause difficulty to intubation. Okay, here's some lab examinations. The blood gas shows the patient have obesity hypoventilation syndrome here. The partial pressure of carbon dioxide raised, and the pressure of oxygen is reduced. And his pulmonary function tests show a restrictive ventilatory impairment and reduced the diffusing capacity. The maximum ventilatory volume, MV, was only 55% of predicted one. And other tests were used, just like we mentioned there, to assess the patient cardiac function. the ECG was normal, and the UCG, they showed enlarged left artericle and left ventricle, but the function is normal. Okay, so what's our anesthesia plan? The key point of this case is how to retain the spontaneous respiration before we can secure the airway, and how to avoid hyperventilation during the intubation. And the third one is how to optimize the parameter of ventilation for this extremely obese patient, and how to avoid obstructive sleep apnea after the surgery. We assess the patient with the obesity surgery mortality risk stratification score, which is usually used for obese patient. And the patient's score is 4, which reached class C, the highest class, which his mortality would be nearly 3%. So our final plan is to, first, for indication, we'll use sevoflurane and dexmedetomidine to sedate the patient, but preserving his spontaneous respiration. And then we should intubate through laryngeal mask airway, which is more easy to place. And then for extra monitoring, we use IBP, invasive blood pressure, and we should monitor the patient's SVV, stroke volume variation, and CI cardiac index with visual. And then we'll monitor the patient's anesthesia depths with BIS. Okay, here's the radio. I tried to use my video, but in the test, it shows the lag is very severe. So would you please let Miss Nie to present the video for me?
Okay, and actually I've tried to send you the video on the WeChat. Would you like to?
Okay.
Because I'm re-recorded.
Okay.
And I'm not sure whether it's gonna be.
I didn't open my WeChat here on the computer. So
oh, it's okay. Then I will open it. I will open it. It's okay. I will take it. Wait a sec. Wait a second, please. Here we go. First one goes to the LMA, right?
Yeah.
Okay. Wait a second.
Okay, thank you. We can see that.
No problem.
Okay. First, we use a mask to give the patient ventilation, and we can see we've already had this IBP and BIS and the visual monitor on the patient, and the patient now is having his own spontaneous respiration. Here we can see on the monitor that this is the endotidal carbon dioxide wave, and this curve can show if there's an obstruction of upper airway. When the curve reduces, that means the obstruction may happen. So so a doctor will tilt his chin and to release the obstruction, just like in the video. And we can see the BIS here. We're now using sevoflurane and dexmedetomidine. And now the patient's BIS is 84, and then it will drop. And when it reaches the right depth for the placement of LMA, we replace the LMA to the patient. So we can go faster here.
Okay, shall we change it? Oh, no.
Yeah.
Go to the LMA, right?
Yeah.
Wait a second. Somewhere here.
Okay. I think it's very difficult to tilt the chain all the way along. So we use an oral pharyngeal airway to the patient before we use LMA, just like the recommendation said. Now you can see the BIS is dropping. And from the curve of carbon dioxide, we can see that he's still maintaining the spontaneous ventilation. Now here we are placing the oral pharyngeal airway. Okay, we can see the BCs dropped to 46, which might be fit to place the laryngeal mask airway. So could you please move forward a little bit faster? Okay.
Over here.
Okay, here BC is already below 40. And then we'll place the laryngeal mask airway. You can see it's very fast and easy, and patient doesn't have any pain through this course. While he still has spontaneous respiration. You can see the curve here after we place the LMA. Okay, here's for this radio. And for next one, would you please show the next one? We use a fiber optic bronchoscope to check the position of the LMA to make sure the opening of the LMA is right opposite to the glottis. The second one, please. Thank you.
Okay, wait a second.
Okay, here, the bronchoscope is already in the LMA. Yeah, we can see that the opening is right opposite to the glottis. And since we make sure that the position is right, so we give the patients intravenous drugs, propofol, sufentanil, and rocuronium, muscle relaxant, and prepare for the final endotracheal intubation. Okay, you can see Dr. Honey is doing the induction for the patient. And since the patient's airway is already secured, we have no concern about the difficult intubation at all. So the next one is the intubation. We again use a bronchoscope to guide our endotracheal tube. Okay, next video, yes. Okay, we use a fiber optic bronchoscope to guide our tracheal tube going through the LMA here. Now we can see the glottis, and then we move forward and then into trachea and push in the tracheal tube. Yes, so that we accomplish the intubation, and there's hardly any hypoventilation through all this course. Okay, thank you for your video, and I'll continue on my slides. Okay. Okay, about the management during the operation. For ventilatory parameter, we use 8 milliliter of the PBW. The mode was choose to volume control ventilation, and pressure limit was set into 40 centimeter water column. And the PEEP was initially set to 5 centimeter water column, which for the expert recommendation for obese patient, it should be 10. But when we perform this anesthesia is only 2018. So we didn't have that recommendation. So we still started with 5 centimeter water column and then adjust it according to the oxygenation index because we already had IBP, so it won't be a problem. And we can test the oxygen, we can test the blood gas and get the right oxygenation index. And we used a manual ARM after intubation and during the pneumoperitoneum and at the end of the operation. Since our anesthesia machine doesn't have the CPAP mode, we choose to do that manual. And for the fluid management and anesthetics, we use sevoflurane and propofol and remifentanil and rocuronium according to the BEAS and TRILO 4. And we used a restricted fluid administration for like 2 to 3 millimeters per kilo an hour. And it is monitored by the Vigilo, the SV was monitored by the Vigilo so that there's no low capacity in the circulatory system. And for post-operation, we transfer the patient to the ICU with the tracheal intubation and we choose to do the extubation there because in this way the patient can be completely awake and that can avoid the OSA after surgery. And the patient outcome is very optimistic. There were no complications at all, and the patient was discharged 1 week after the surgery. So that is for the case. And thank you for your attention. This is all for my content. Thank you. Thank you very much.
Hey, thanks to Dr. Zhang a lot. And I'm pretty sure that after such a fabulous speech that we can get tons of information about perioperative lung protection. And Dr. Zhang tells us in details like from biology and to clinical application and from anesthesia machine to patients to medications to case reports to show what can we do and what we should do during our daily work, especially like in this case, this is an obese patient, and what can we do to try to get him as get much protection as possible during the surgery, and so we can keep them have a better outcome after the surgery to reduce the PPC's post-operative pulmonary complications. And thanks to Dr. Zhang again. And now I will take a very short time to give a brief introduction of our anesthesia workstation, Aeon 8800A. And after this part, we could have a very directly discussion to our Dr. Zhang and Dr. Hong. Wait a second, please.
Okay.
And like the major, you can see my slides. Okay, and like the topic of our speech today is the perioperative lung protection, and Aeon 8800 anesthesia workstation is purely and to no matter it's qualified and to meet our clinical requirements. And actually this was mentioned in Dr. Zhang's speech also. When we are talking about the mortality rates and even morbidity, and from these charts we can see that the first one is that the deep dark bar is much higher than the light one, right? And this is the mortality rates with PPCs. This is for the first year after our patient had the surgery, and this is 5 years after my patient had the surgery. And with the PPC, the patient's mortality rates is much higher than the one without PPCs. So when we're facing up to these clinical questions, we're trying to help solve the problems. Aeonmed is trying to protect our patients' lung and also protect our persons. It's not only our patients, it's also our doctors. What is lung protective ventilation? It's already explained by our Dr. Zhang already clearly, so I won't spend too much time here. And at least we need to have low tidal volume, individualized PIP, and minimize impact recruitment maneuver. And why we need it, and I think that's why we're here today, right? At least we need to reduce the 3Ms, morbidity, mortality, M&M in our hospitals, in our ORs. It's always a very, it's always a topic that we need to take consideration into. And also to reduce the money 3Ms. This one is not only talking about the hospitals or anesthesiologists. No, this one is for our patients, because when we have the post-operative pulmonary complications, my patients gonna have like they prolong their hospital stay time, and they need to spend more money, spend more time to cure their, like the Dr. Zhang mentioned before, the atelectasis, the pulmonary edema, or the emphysema, this kind of risks or this kind of pulmonary complications. So try to give a lung protective ventilation during the surgeries, trying to reduce the 3Ms, morbidity, mortality, and my patient's money. And why is our EN 8800A this anesthesia workstation? And both of us mentioned before, we need to do the low tidal volume, and we can see from top to bottom, once the tidal volume gets bigger, the risk of PVCs is getting higher. So it means that try to use the 6 to 8. This is kind of the routine, the calculation we need to use during our daily work in the OR. And of course, I understand, because I was an anesthesiologist before, and when I was in the OR, like the 60 kilo or 70 kilo, especially the female and the male, there's something different there. And also we need to depend on the specific patient's condition to change the tidal volume. But anyway, when the first time that we need to calculate the tidal volume, we suggest to use the 6 to 8 ml per kg. And for the EN 8800A anesthesia workstation, we have the 10 to 1500 milliliter tidal volume to help our anesthesiologists in the OR to face up to the diverse patients type and to different clinical requirements. And the second one, we need to have the individualized PIP, because every patient in my OR and in front of me, it's different, has the different conditions, right? Of course, hopefully I could have every patient, have every healthy lung function, or they're not smoking, or they did not do anything harmful to their lung. But we know that it's always, like, especially for the elderly, we have COPD or asthma or some kind of chronic lung disease. So to give the individualized PIP to each patient is pretty important, pretty vital to do the lung protective ventilation. And in our anesthesia workstation, EN 8800A, we're the first one in this world, and now still the only one to put these two monitoring parameters in our anesthesia workstation. The first one is the driving pressure, and we can see it here. The driving pressure usually suggests to below 13 to 15 centimeter water. And after we see driving pressure here, and we can intuitively to understand whether my patient's PIP is okay, and his or her tidal volume is okay and is suitable for these patients. And in this article published in New England and Lancet, it shows that under the patient under the protective ventilation versus conventional one, the driving pressure give a very statistical difference between these two groups. So the driving pressure is a pretty good and intuitive monitoring parameters help our anesthesiologists to see whether we can have a very simple individualized PIP to my patients. And also the stress index. This is we can combine them together to see. This one, stress index, it's also named monitoring parameter. Usually we're talking this in our ventilator or critical care area more openly, but here we put it on the anesthesia machine, and we can combine this driving pressure and the stress index together to give a judgment whether my patient's tidal volume and PIP is suitable for these patients. And this one, just to exposure to see whether my patient's these breath is alveoli recruitment is with or without over distension. If this parameter is around 1, like 0.98 to 1.01 or 1.02, this kind of change or this kind of range is okay for this patient to say, okay, the tidal volume, how much gas I give to this patient is enough. But once it's getting bigger and bigger, it's much bigger than 1, like 2 or even 3, it means that it's over distension. Probably it's gonna have the volume trauma. And on the contrary, when it's going smaller and smaller, like 0.8 or even 0.7 or 6 around this, we will know that is not enough. The tidal volume and the PIP is not enough for my patient. After such a long time, my patient probably will go through the hypoxia. And here, the PIP tool we put in the anesthesia workstation, A800A. It's pretty easy for my anesthesiologist to titrate how much and what is the suitable tidal volume and PIP for my patients. So like Dr. Zhang mentioned before, after every ARM, alveolar recruitment maneuver, we need to titrate the PIP every single time, right? Because it's changed again and again. So this tool helps us to have a good way or process to get which PIP and which tidal volume is suitable for my patients for now. And the next one is to minimize impact recruitment maneuver. And I'm pretty sure that all of us have the same experience in the OR. Once I did the thoracic surgery, they open the chest, and my thoracic surgeon just to see after everything's done, and my thoracic surgeon see into the chest and talk to me. Hi, Mary, just give me some recruitment. I say, oh, okay. Then I would just turn the APL valve into like 30 or 40 centimeter water, and then I would squeeze the reservoir back, and I will see into the chest and will see, okay, the lung is getting bigger and bigger. And my surgeon told me, it's okay, you're done. And okay, my recruitment maneuver is done. And I'm pretty sure, kind of this is based on our experience or something like that. But here now we can do the recruitment by our anesthesia workstation. We don't have to based on the experience. We will test, and my anesthesia workstation will tell us whether it's okay and whether this pressure is good, is suitable for these patients. And also, we will have to have an eye on the metabolism to see the blood pressure and to see the heart rate if it's going to like the. Of course, we cannot give any. We don't want to give any impact on the circulation. So here, we don't have to worry about that once my anesthesia workstation could give me the information about what can we do. And here, we have two ways. The first one is sustained inflation. It's kind of our manual recruitment maneuver, is just give once a time. And we set the PIP target, and we set the PIP and T-slope and everything here, and we're done. Just start and we're done. And the next one is PIP increment. The PIP increment is that we can set the PIP start and then how much I added once a time. Like I need 5 circles and started from 5 centimeter water, and I add 5 centimeter once a time, and 5 plus 5 plus 5 and plus 5. And finally, I will individually to open my lung and then keep my lung open. And that's all about our lung protective ventilation, no matter the lung protective low tidal volume or the individualized PIV about the driving pressure and the stress index, and our PV tool to give our patients the most suitable setting for them. And the last one, our recruitment maneuver. And here is our clinical tool, another clinical tool we call CPB. And actually during the open chest CABG, usually I understand, usually we do not give any ventilation because our cardiac surgeon needs very precise operation during the surgery. But on the research, we can tell that during this silent time, especially for our lungs, during this silent time, if we can give some ventilations to our patients after the surgery, after the no matter the CIBG or the open chest lung, open chest cardiac surgery, my patients will give a better outcome to reduce the PPC. So we have the 3-way. The first one is the IPPV. We can turn it in the very small tidal volume and a very, very low frequency, like around 3 per minute. This kind of frequency, and we will give a little bit to them to make my lung in a complete silent condition. And the second one is pressure CPAP, is just give a very, very small continuous positive airway pressure to keep my patient's lung open. And of course, if we don't have to do anything about that, of course we can do it. It's just pulse glow. And also during this process, we will mute all of the alarms. I understand I don't want to always listen to the apnea alarm, bing, 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 every time there, right? And the last one for the software is the intelligent delivery for fresh gas. The first one goes to the it's pretty easy for us to change the flow. And there are 2 ways here. The first one is we change the oxygen concentration here, and then we set how much flow I need, and we're done. And we don't have to calculate how much the nitric oxide combines how much the oxygen. No, we don't have to calculate it. We just change the oxygen concentration here and set how much flow I need here, and we're done. And the next one is, this one is more like the classic one, right? Into independent each gas, the air or the oxygen or the nitric oxide, to have the how many liters per minute for each gas. And this is for the electronic flow meter. And this one, the echo optimizer. The echo optimizer is kind of like indicator to give us the indication that whether now the flow is enough or it's too much or it's too less for my patients. Because we understand that especially after the COVID-19 pandemic, the oxygen gas resource is getting precious. It's getting more and more precious. So as we don't want to waste any of our oxygen and our precious oxygen gas resource here. So, and of course, sometimes we give too much flow to my patients. After the surgery, my patients will complain to me, I not feel very comfortable because I saw that in some other countries, I saw that they turned the gas total into 6 or 7 liter per minute. So what? That's too much for my patients. And we have the PCV-VG and we have the SIMV-VG and 5N and APRV, different such a diverse ventilation modes here in our anesthesia workstation to help our anesthesiologist to face up to more and more complication clinical here. And the next one is going to the hardware. And this one is always the spotlight I first go to. Aluminum alloy breathing system, we don't have to worry about any deformation or any of the cross infection. After like we have the TB, tuberculosis patients or HIV patients, we just take all of these breathing system into the sterilized oven and we're done. And it's fully autoclavable, so we don't have to worry about anything under the high temperature or high pressure. And also the flow sensor here, we made it integrated. It's a built-in one. So we don't have to change it like half a year or once a year. And we don't have to worry about damage or if somebody, from other departments, the intern just came into my OR and just throw it away. And I lost my flow sensor. No, we don't have to worry about it. And then we have the unique patterns in these two, and that's why we're confident enough to put it in. And next goes to the fast release function of APL valve. That's just help us because during the induction and the resuscitation, we just to squeeze it back and forth, right? And here we don't have to just tilt it and pull it up, put it up and release all of the pressure there. And the ceramic valve, one-way valve, it's because the ultralight of the ceramic one-way valve, it means that it's ultra sensitive to the extreme light breath, especially for our pediatric patients. And our CO2 bypass help us during the surgery that we don't have to worry about there is any interruption if I want to change the soda line. And also our EN 8800A and Fisher workstation will have a driving gas auto switch. This is an optional one, but once it also helps us to save the oxygen gas resource. So once my medical air, my anesthesia workstation could sense there is medical air, it will auto switch to use the medical air to use as the driving pressure. It won't use the oxygen. And the ACGO protective power cover here. So there will be no misconnection like here. And also we can monitoring the 5 anesthetic agents, Civil, ISO, and fluorine, nitro oxide, and difluorine. And AGSs, we have the passive one and the active one too. This just depends on whether we have a central vacuum in the OR. If we have it, of course, we can have the active AGSs. If we do not have it, we can have the passive AGSs to keep our environment in the OR to as clean as safe enough. And also aging consumption calculation, the suction system, I understand the suction system in the OR usually is much bigger than this, but this we can take it as a backup one. And the pendant mount adapter means that the whole anesthesia workstation of ER 8800 could hang on the pendant. We don't have to need these wells and the central bag. If we don't want it, we can just take out it and hang all the anesthesia workstation on the amount. And yeah, this is our 88,000 series Aeonmed anesthesia workstation. Eon 8300A. Here it goes to, this is a very compact design for the different size OR, and our 8600A and 8800A, these kind of like how to say, it's like it's up to you which one to choose. This one have a bigger screen, so we can see it more intuitively, and all of these are our middle to high end anesthesia workstation. And also, our Dr. Zhang mentioned that we can have the non-invasive positive ventilation before the surgery. Yes, of course, it's probably not a very clear or not a very such an vital in factor before the surgery to have my patients to have the NIPPV, but still our Aeonmed group is have a very strong team. We have not only anesthesia products, and also we have the ventilators, and here VG70 is our superstar, and it's a turbine ventilator. It contains invasive ventilator and also non-invasive ventilator, and it's pretty easy for us to take it to carry it on. So in the hospital, to transfer it in different departments, it's pretty easy for our, no matter anesthesiologist or our critical care doctors to use it. It's pretty easy to use, and also it contains both of the ventilations, non-invasive one and invasive one. And this VG55 is a pure non-invasive ventilator, and also this I7 is an HFNC products, high flow nasal cannula respiratory product. So combine all of this together, and also with our young anesthesia workstation, we have the complete product in our company. And thank you very much for your attention. And I'm Zhang here, and next we will go into the Q&A part. And first we will see. If you have any questions or concerns, we will have a discussion here. Let's see in the chat box. Yeah, I understand, because after Dr. Zhang's fabulous speech, there are tons of information we need to chew it, to digest it. And I will, may I have the question first?
Of course, please.
Yeah. And actually, I'm curious about like before the patient is in the OR, especially for the elective operation, they need to do series of examinations in the OR. So except the X-ray, right? And the CT scan, I think it's kind of not the must-have one, right? The CT scan, it's a right? So, what kind of other exams that can your have the most recommendation before and after, no matter the elective operation or the emergency operation, please?
Um, okay, based on my experience, for ordinary patients, or to say the low risk patients, I think X-ray or CT, which kind of doing the same thing, is already enough. And if the patient can cooperate, I think doing a breast holding test, just let the patient hold the breast and we count for the time, might help us to judge the patient's lung function quickly, and is very convenient to do. And for those patients with high risk factors, especially with the pulmonary or cardiac complications, I think we need to do the blood gas test, as I mentioned, and lung function, and I think the ultracardiography might be helpful to understand the circulatory function. And but these two, the last two are quite time consuming. So I think maybe for a emergency situation, at least the blood gas should be tested before the surgery. Yeah, I think so.
I think the blood gas analysis is very important for those people, patients. And the X-ray is not very important, but can include a lot of patients, and the blood gas analysis is very important.
Okay. Okay. So not only the physical one, also our chemical one, like Dr. Hong said, the blood gas analysis, no matter for the elective patients or for the emergency patients. And
Yeah.
at least we can, to compare the FiO2 and the PaCO2, right?
Mhm.
Okay. And I can see in our Q&A box, does a small tidal volume necessarily play a role in lung protection? And does lung protection necessarily reduce mortality rates? Okay, so the first one goes to whether the small tidal volume is necessary in the lung protection, and the second one is does lung protection reduce the mortality rates?
I think yes. Just like I mentioned in my slides, there's a picture showed all those studies there, right? So it includes the studies nearly for 20 years, and all those studies about the tidal volume and PEEP showed a positive outcome for reducing the PPCs. So I think, of course, it's necessary. And if we don't talk about the studies, from my experience, I think the lower tidal volume can reduce the driving pressure, of course. So I think somehow it's useful. And for the mortality rate, I think it's hard to say based on the experience, but I think now we are all now using the low tidal volume, and at least during the inpatient period, the complications are rarely thin. So I think it works. Yeah.
Okay. Yeah, I get it. The first one is that yes, of course, the small tidal volume is good for our patients. We can have the tons of status from our research before. We can see it in no matter in the PubMed or what this kind of database. And also, to reduce the mortality rates, of course, there are so many complicated reasons there, but once we do the lung protection there, I'm pretty sure that we do something good for our patients to help them to get a better outcome there, right?
Yeah.
Okay. And let's see in the chat box. All of our doctors are so interested in your slides there. Yeah, actually me too, especially, yeah, the no matter the academic point of view, yeah, it's pretty in detail, and also the case report. And our handsome Dr. Hong was there.
Yeah, actually,
And
about the case, he performed the anesthesia for that patient. So if you have any questions about the case, you can directly ask Dr. Hong how he was considered about the problems there. Yeah.
Okay, I say something about the case. And first, I would like to thank Dr. Zhang bring us so interesting lecture. And also thanks to Mary Nie. And the case was performed by me, so I like to say something about it. And this is a very special case, which the patient is an obese patient, and too much weight bring a lot of problems for me, for us, and for the anesthesia. First off, the management of the airway is urgent. So intubation for such a patient may very difficult. So we use the laryngeal mask as the first step to establish the airway, just like the video in the slides. After that, the intubation becomes easier and safer. And then the second problem is how to protect the lung functions, because the heavy weight, the patient's weight is over 200 kilograms. So the lung will be compressed by the organs in the abdomen. Ataxia will need to be controlled by alveolar recruitment maneuver. That means ARM. So every 30 minutes maybe. So to open the lung, just mentioned by the Nie. And then, as we know, the lung is very special organ. All blood will go through the lung. But for other organs, the only accept part of the blood of the circulations. So the poison substance and the inflammatory factors in the blood will all go to the lung and then injure the lung. So we need to control, we need to care the lung very carefully. That's because the lung is vulnerable. So thank you. Okay.
Okay, thank you.
yeah, many thanks to Dr. Hong. Yes, like he mentioned, lung is such a special organ that it's kind of like connect our input to the outside environment to get no matter the blood and gas exchange. There are so many things happen there, and we have so many things in our lung. We need, it's such a vulnerable organ. We need to protect it.
Yeah.
And may I have a question about the extubation about this case, please? How like after the surgery, how long you guys take to extubate the patient?
I forgot it. I think maybe after 24 hours, after maybe 1 day.
Okay, yeah, I think because it's such a novice patients, usually we do not do the extubation right after the surgery. We need to have we need to see see what everything is done, everything is ready. Otherwise, when we need to re-intubate it, it's much difficult than the first time.
Yeah.
Yes, after the operation, we transfer this patient to the ICU. So after that, when the extubation is performed, I don't know exactly. Okay, so maybe 1 hour, maybe 24 hours.
Okay, so this gonna be your routine process to send this kind of patients to the ICU after the surgery, right?
For
This is
such a patient,
recommendation.
yeah. So for such a patients is obese patients, yes, it is routine transfer to
Yeah.
ICU.
I think it might be depend on the OSC situation, because now we have a lot of these kind of banded gastroplasty operating every year, and we didn't send all the patients, all the these patients back to the ICU. But if the apnea or OSA is not severe, we try to extubate the patient after surgery, and we'll just took more time in the PACU to watch the patient's breath pattern and see if he or she don't have any a sleeping apnea, we can send the patient to the ward. We just let the patient stay longer in the PACU and not in the ICU. So I think reducing the mechanical ventilation time is quite important for the patients. So yeah.
Oh, I see. So it depends. It depends. No matter it depends on the patients. Depends on the how long my patients are getting mechanical ventilations. It's also it's something about the surgeries, right?
Yeah.
Okay. I see. Thank you. And so I see there are 3 doctors hands up here. So Pharaoh, shall we open their microphone, please?
Oh my. Pediatric patients.
How about unprotected ventilation in pediatric patients?
Okay, for my experience, which we don't really have that much of pediatric patients, but when we perform mechanical ventilation to the pediatric patients, with my experience, I intend to choose the pressure controlled ventilation for the pediatric patients because, of course, we choose a we set the limit to the 30 centimeter water column, and so that of course there's a accelerated rate for over 20 BPM, and I've never used PEEP on the pediatric patient, but I've heard that when there was a doctor from England, they came to the hospital, and when he performed those anesthesia, he said he always performed PEEP on pediatric patients, but I don't have that kind of experience. What from my experience that I use the pressure control mode a lot. Yeah.
Yeah. Yeah, makes sense because for the pediatric patients, it's always because the biology for pediatric patients and adult patients, there's so many differences there, and we need to care much more careful for our pediatric patients. And for the PIP, and yeah, as long as we at least we need to to take care to use it, like no matter it give any impact to the right ventricular or even the left ventricular functions, getting any adverse impact there, we were gonna lose more. So as long as we do something careful there for our pediatric patients. And but I think the no matter the low tidal volume and the individualized pivot it depends, and the minimize the impact recruitment maneuver, it's always something that we can take into consideration for our pediatric patients.
Yeah.
And let's see. And I think if actually our time is kinda time up, and we can see these three that I'm sorry. This the patients who is raising your hands, we've already opened your microphone, and you can open it up to talk to our Dr. Zhang and Dr. Hong directly. And if we are kind of done today, and I think it's time to say bye bye here, right? So
Okay.
yeah, thank you to all of you. Thanks to Dr. Zhang, and thanks to Dr. Hong to give us no matter such a good speech, and also for this fabulous case report. All these patients is always have a complicated process we need to do by our anesthesiologist. We need to take care of their circulation. We need to take care of their airway, their lung function during the surgery. And thank you all of you to be here to with us have a discussion with our professors here. And wish we can see you guys soon. And today we're done here, and have a good day. See you next time. Bye bye.
Thank
Bye-bye.
you. Bye-bye.
Thank you.
Thank you.
Bye,
Thank you
thank
very
you.
much.
Thank you.
Thank you.